So we are right on time. We've got coming up on 240 participants, so that's wonderful. I'm so excited to introduce our next speaker. This is Dr. Tim Rowe. He's going to speak to us about the new hot off the press 2021 SOGC guideline on managing menopause. Dr. Rowe is a world-renowned menopause expert. He graduated in medicine from the University of Adelaide and completed his postgraduate training at Dalhousie and the London Hospital and the University of Sydney. Dr. Rowe is Associate Professor Emeritus in the Department of Obstetrics and Gynecology at the University of British Columbia, having been the head of the Division of Reproductive Endocrinology and Infertility until 2013. From 2005 to 2016, Dr. Rowe was the editor-in-chief of the Journal of Obstetrics and Gynecology Canada, and he edited the SOGC's clinical practice guidelines on menopause and osteoporosis in 2004, 2006, 2009, and 2014. And he's a contributing author for the 2021 SOGC CMS guidelines in menopause. In 2017, he received the SOGC's Distinguished Service Award, and in 2019, he was awarded the honorary membership in the Canadian Medical Association. He is a member of the board of directors of the Canadian Menopause Society. Need I say more? We have one of the foremost experts in menopause in Canada, and I will ask Dr. Rowe to take over now and share his screen.
Great. Thank you very much, Caitlin, and thank you for this invitation. Now I'll just make sure I can get this. Sorry, we ended up in the wrong area. Okay, so thank you again for the invitation, and I have two shout outs at the beginning. The first to Jenny and Nancy at PCRM. I miss all of your smiling faces. But second, and perhaps more relevant, on Friday morning, the Canadian Menopause Society and SOGC will be hosting a half-day symposium with the lead authors of each of the chapters in these new guidelines, giving some more information about them. And I think that's a session that you shouldn't miss if you are interested in menopause management, and I think increasingly we all are. The next thing I have to say is I apologize for this presentation being mostly words, because that's what guidelines are. And unfortunately, I can't make zippy slides like Caitlin's, so forgive me for not having wonderful visuals, although I try to keep it from being totally boring here and there. But my objectives for this afternoon will simply be to go over the recommendations for management of the menopause guidelines, identify how they've changed in the past couple of decades, and wherever possible, compare these Canadian recommendations with what's being said internationally. The guidelines are being published in a relatively new format, in that there is at the beginning a statement of how practice should change as a result of these guidelines. It's not altogether satisfactory, and the set of the guidelines that I have, which is pre-publication, did have some omissions that I thought could have been remedied by more attention to how practice exactly is changing. But they do include a summary multiple summary statements about the section of guidelines that they're referring to. And they have a series of recommendations, which in some cases are more or less relevant. So I'm just going to go through, if you don't mind, the things that I have to do at the beginning. My presentations, I think, won't be relevant here because I'm not mentioning any brand names, but always talking about generic products. When I talk about international preparations, there are any number of guidelines relating to menopause published internationally. And the SOGC ones were well overdue for review and repeat publication. You can see it's taken 7 years to get this revision done. And in the meantime, there have been a number of publications from the International Menopause Society, the NAMS position statement in 2017, and a couple of years ago, the Global Consensus Statement on the use of testosterone therapy, which again is relevant and will be referenced as I go ahead with these outlines. So I'm just going to go through the recommendations from each of the sections of these guidelines, and then we'll talk briefly about how practice should change. So the areas of focus in these guidelines are these: indications for treatment and the options for treatment, mood, sleep, and cognition in menopause, cardiovascular disease in the menopause, genito-urinary health, sexuality in menopause, osteoporosis, which again is not usually a feature of menopause guidelines, and these Canadian guidelines are an outlier in that respect. And finally, the important consideration of breast cancer in menopause. So again, going ahead with what the recommendations are for each of these, I'm just going to be reading the statements that they make and offering some parenthetical comment. The indications for treatment section is probably, as you expect, that vasomotor symptoms and sleep disturbance have the ability to have a significant effect on quality of life. And that's probably stating the obvious for all of us who manage menopausal health. But in the management of vasomotor symptoms, menopausal hormone therapy is the most effective option, and it can be safely initiated in women who don't have contraindications if they are less than 60 years of age and less than 10 years post-menopause. And this is something that is new since the last guideline, and I think has become pretty much accepted internationally. Interestingly, in Canada, Health Canada does not offer indications for hormone therapy. That's not the way the Canadian system works. But in the US, the FDA determines what drugs can be used for what reason. And the NAMS position statement from 2017 noted that the FDA says hormone therapy in women is indicated in 4 scenarios: where there are bothersome vasomotor symptoms, for the prevention, but not treatment, of bone loss, where there is premature hypoestrogenism, whether that's caused by interventions or spontaneous ovarian insufficiency, and genito-urinary symptoms. So that is a difference from the Canadian guideline, because mostly the indication for treatment in Canada is deemed to be vasomotor symptoms and effects on quality of life. The options for treatment cited in this section are estrogen and progestogen for women with a uterus, or now the possible use of the tissue selective estrogen complex, combination of conjugated estrogen and bazodoxifene, which is currently, as you all know, off the market because of a packaging issue, not because of any problem with the contents. And since mid last year, tibolone. In women who have had a hysterectomy, estrogen alone is an option. There is a fairly appropriate statement about compounded bioidentical hormone therapy, noting that there is no accepted definition of what bioidentical means, but it's generally accepted to mean biologically identical hormone therapy and used in compounded preparations. And they do say, again, with some clarity, that these bioidentical preparations have not been assessed with the same rigor as those products approved by Health Canada for pharmaceutical companies to market in Canada. And essentially, it says don't use the compounded preparations unless there is an allergy to all of the pharmaceutical preparations, or there is the need for specific individual dosing. The non-hormonal prescription therapies, which include the antidepressants, SNRIs, SRIs, gabapentin, clonidine, and oxybutynin can be used to treat hot flashes, but they do tend to have their own side effects. Increasingly, cognitive behavioral therapy is cited as an option for the management of vasomotor symptoms, particularly in women with contraindications to hormones. But it's not something that somebody can just pick up a book and do, and it does require resources that are not available everywhere. Natural health products gets a passing mention in this section of the guideline, saying that they probably do no harm, but there is very little evidence that they will be effective in controlling significant hot flashes. And the additional thing that has appeared in this set of guidelines compared with previous ones and with all the international ones is the observation that, again, particularly appropriate in Canada, a multicultural country, that cultural humility and cultural safety should be taken into account in prescribing for menopausal women. And it may be important for any of us managing women with menopausal complaints to do so in concert with a cultural leader from the group that the woman belongs to. So this is a new consideration that has been stressed in this section of the guidelines. Moving on to mood, sleep, and cognition. The statement is made with some emphasis that any menopausal woman developing depression should still be managed as if she was not menopausal, but as if the depression was an isolated concern. They do draw the distinction between depressive symptoms and major depressive disorder, and says that depressive symptoms are common and major depressive disorder less so, but they should still be managed primarily with the standard managements for depression, that is, use of antidepressant pharmacotherapy, cognitive behavioral therapy, or behavior-based psychotherapy. Women who have recurrent episodes of depression during the perimenopause, it is important to consider response and tolerability with previous trials of antidepressants. But again, women who have new onset of depression, particularly in the perimenopause and postmenopause, you do have to consider the effects of treatment on quality of life, and particularly in women, for example, who are being treated for breast cancer and need tamoxifen. There is an interaction between certain of the SSRIs, particularly paroxetine and sertraline, and tamoxifen metabolism, so that the action of tamoxifen in these women may be interfered with those SSRI agents, and so you have to take that into account. Hormone therapy has a beneficial effect in some women with some perimenopausal women, whether or not they do have hot flashes. So it's tempting to use particularly transdermal estradiol as a primary treatment in perimenopausal women with new onset depression. But you need to do so advisedly. And I think there will be further information coming about the role of hormone therapy in treating perimenopausal depressive symptoms. Sleep disorders are very important to consider in the menopausal transition. Women whose primary concern is poor sleep do require support regarding sleep hygiene and the ability to have sleep undisturbed by menopausal symptoms. So primary sleep disorders do need to be ruled out, including sleep apnea, anxiety, and so on. But remembering that hot flashes are a significant contributor to sleep disruption, hormone therapy may well improve sleep just by controlling vasomotor symptoms, but there is also an independent effect of both estrogen and progesterone on sleep patterns independent of vasomotor symptoms. There are other options for managing sleep disorders, including one of the forms of cognitive behavioral therapy, aerobic exercise, and I'm sure you're all familiar with the other options available. So for women who do have concerns about cognitive decline, it is important to maintain general health. And one of the newer statements in this guideline was the importance of including vegetables, although I think they did say fruit and vegetables, but vegetables seems to come through in the recommendation, reducing the rate of cognitive decline, and also limiting comorbidities, the potential adverse vascular effects of hypertension, diabetes, and atheroma. And they say in the summary statements that menopausal hormone therapy hasn't been shown to significantly improve measures of cognitive function over several years of use. But I think it should also say yet, because cognitive function is relatively a new focus in postmenopausal women, and there is increasing observational evidence that cognitive decline is slowed in women who begin and continue menopausal hormone therapy. Cardiovascular disease, this is a very cautious guideline, and it does say things that perhaps are obvious, and the guideline is less apt to take a position about areas of cardiovascular disease which are perhaps more questionable. I would just make some comments about that. The recommendation in the guideline is that because of the association between estrogen therapy and venous thromboembolism, the recommendation from a cardiovascular point of view is that women taking menopausal hormone therapy should take the lowest effective dose of estrogen, and they include transdermal estradiol in this concern in minimizing the risk of stroke. I think there is substantial observational evidence, which they refer to parenthetically, that the use of transdermal estradiol does lower the risk of venous thromboembolism and stroke, but they feel that overall, from a cardiovascular standpoint, the dose of estrogen should be as low as possible, whether it is administered orally or transdermally. They also note that different progestogens have different effects on markers for cardiovascular disease. This is information from the 90s with the original PEPI trial, which was the first to show that the effects on HDL cholesterol of micronized progesterone and synthetic progestogens, specifically medroxyprogesterone acetate, were different, and the use of micronized progesterone appeared to be preferable if you were looking at impact on markers for cardiovascular disease. The use of a tissue-selective estrogen complex, that is a combination of conjugated estrogen and the serum bazodoxifene, does provide uterine protection and controls menopausal symptoms, and they do not, this particular agent doesn't appear to be associated with cardiovascular risk, but again, it's currently unavailable because of packaging concerns. Genito-urinary health is recognized as an area that has been underserved in years past, and increasingly a number of agents are being made available to improve genito-urinary health. which, as the name suggests, can have genital consequences, urinary consequences, or sexual consequences. And the recommendation from this guideline is that women who are perimenopausal or in the early postmenopausal years should be informed that their urogenital health may decline and that there are multiple options available for relieving symptoms. They also recommend that women should be screened and screened continuously, or at least on an ongoing basis, for genito-urinary symptoms, simply because they manifest generally later than the more immediate symptoms related to menopause. They recommend that first-line management should be non-hormonal, use of vaginal lubricants or vaginal moisturizers, and that vaginal estrogen can be second-line therapy. And they do stress here, but they're more cautious in the breast cancer guideline, that significant absorption of estrogen doesn't occur with low-dose therapy. So there's no need for concomitant progestin therapy. There are newer options available which have become approved by Health Canada since the last guideline and since some of the international guidelines. Specifically, these are the oral SERM ospemifene, which has been approved by Health Canada now as an oral agent for management of atrophic vaginal symptoms, and vaginal DHEA, which has been available for some time in the US and has recently been approved by Health Canada, but is not yet marketed in Canada. And the use of the intravaginal laser therapy, the Mona Lisa treatment to manage genitourinary syndrome of menopause, is acknowledged as a potentially effective form of treatment, that it doesn't carry any of the hormonal concerns of the other treatments, but they stress that its use should be carried out within the protocols of clinical trials in order to be sure about long-term consequences. The sexuality section of the guideline this time is less extensive than it was in 2014. I don't know if that tells us anything, but it is a useful guideline that recommends, again, that sexual screening history and physical examination should be an initial part of the evaluation of menopausal women. And they do mention that every clinician managing menopausal women should be familiar with the PLICIT modality for managing sexual health. PLICIT, I'm not sure if you're familiar with this, but it's an acronym, PLISSIT, standing for permission, limited information, specific suggestions, and intensive therapy. And all clinicians really should be capable of providing each of these up to specific suggestions, with intensive therapy reserved for subspecialists. The management of vaginal atrophy related to menopause in this guideline can include vaginal estrogens, lubricants and moisturizers, vaginal DHEA, and ospemifene. Women who have HSDD, hypoactive sexual desire disorder, there is mention in this guideline of the option of prescribing transdermal testosterone, noting that this is off-label, or the serotonin agonist/antagonist flibanserin, which has been shown in premenopausal women to increase desire, and actually recently in one postmenopausal study. The transdermal testosterone statements in the guideline are not entirely satisfying, in that the international consensus statement did say that transdermal testosterone could be used in women with HSDD, but recommends against the use of compounded preparations leaving us hanging in Canada because there is no preparation marketed for women. And in this guideline, they recommend using a half pump of 1% testosterone gel, which is 1/10 of the dose used in men. But I'm not sure what a half pump is or what the actual gel that's recommended is. So it's a fairly vague recommendation. Women who are post-breast cancer and who have developed symptomatic genital or urinary symptoms, they can use local vaginal estrogen if there is agreement from the oncologist, and particularly after discussion if these women are using aromatase inhibitors. The osteoporosis guideline, as I said, is not part of the other international menopause guidelines. So it is a fairly specific part of the Canadian guideline. And the recommendations are, again, quite specific. These are the recommendations that they make. And I think make common sense. I don't think there is a lot of change from 2014. Just a couple of new agents that have appeared. But the recommendation is, again, that all adults, men and women over 65, should be screened for their risk of osteoporosis-related fracture. In women under 65, if there are clinical risk factors, then there is an indication for bone density study. All women who are found to have a high risk of fracture because of osteoporosis, and this is usually from the FRAX calculator, that is a more than 20% risk of major osteoporotic fracture or more than 3% risk of hip fracture, should be treated with a pharmacotherapeutic agent. And after a first fracture, the risk of another imminent fracture is high. So women who have a fracture should begin drug treatment right away. Now, again, women with intermediate risk of fracture should be given pharmacologic therapy, and usually this means bisphosphonates, and ideally for up to 5 years, after which you can consider a drug holiday. Women who are at high risk of fracture can be treated with denosumab, which is the rank ligand analog, and will encourage reduced bone resorption. Teriparatide is an anabolic agent which can be used in women with high risk of imminent fracture, followed by an anti-resorptive agent. And the newest one, romosozumab, which is a sclerostin antibody, a monoclonal antibody, as the name suggests, to sclerostin, is an anabolic agent which helps in remodeling, and it actually appears to be superior to bisphosphonates and to denosumab in women at high risk of fracture. So it can be used after, up to a year, and after that, switch to an anti-resorptive agent. The use of raloxifene or bazodoxifene will reduce the risk of vertebral fracture, but not hip fracture, and can be used in women who are at increased risk of breast cancer because these agents have negative effects in the breast. And there's passing reference to the use of menopausal hormone therapy if a woman is symptomatic and ordinarily would be offered menopausal hormone therapy with the additional benefit in reducing bone loss. The guideline recommends daily weight-bearing exercise and at least 1,200 milligrams of calcium in diet and supplements, and at least 800 international units of vitamin D per day. And the last guideline refers to breast cancer, and clearly this is one that most people will read. It's a cautious guideline and says that for motherhood reasons, you prescribe hormone therapy that confers the lowest possible breast cancer risk, but there's argument about what that regimen actually is. And they do recommend that risk factors such as weight, smoking, alcohol use, and exercise should be considered in menopausal women who are considering hormone treatment. Women who are having vasomotor symptoms post-breast cancer have a number of non-pharmacotherapeutic options for controlling their symptoms, including the ones we've referred to. Non-hormonal alternatives, they do cite venlafaxine as the first-line option for management of vasomotor symptoms, but they also mention paroxetine, gabapentin, oxybutynin, and clonidine as other non-hormonal options, stressing again that paroxetine should be used cautiously in women receiving tamoxifen because it may reduce the production of the metabolic product of tamoxifen, which results in its therapeutic benefit. And non-hormonal options, which again are frequently needed in women post-breast cancer, include the same things that were referred to in genito-urinary health. They say local vaginal estrogen can be considered, and clinical trials are ongoing to establish the safety in women taking aromatase inhibitors, because the intent there is to eliminate all circulating estrogen activity. The vaginal DHEA and oral ospemifene are cited again in the women post-breast cancer who have genitourinary symptoms, because these are potentially helpful, but they do stress that further studies are needed to ensure safety. There is no black box for vaginal DHEA. Oral ospemifene is generally considered not recommended in women post-breast cancer at present. And if a woman is able to take estrogen alone, then there is evidence that oral conjugated estrogen from the WHI estrogen-only arm does reduce the risk of breast cancer in women subsequently. So those are the recommendations from these guidelines. I apologize, they are all words, and you will presumably target what you're interested in. If you do read these, you're not going to read them cover to cover. But I think an important part of the way they're presented is, do they suggest current practices should change? And my question, do they align with guidelines from other professional associations? Because I've had to read all of these other things. Well, their changes in practice, again, are a bit spotty and I think less specific than I would have liked. And I had to put in some sort of visual. So practices do change, and we do have to acknowledge that sometimes guidelines from 2014 are no longer appropriate. But in therapeutics, I think it is different from 7 years ago to say that we do not begin hormone therapy, that is estrogen-based hormone therapy, in women who are more than 10 years post-menopause or older than 60. So it is safe as an option for women in their 50 or less than age 60 and who are less than 10 years post-menopause. And the reason for putting that line in the sand is that women who have established any kind of established atheroma will have some potential destabilization of that atheroma if estrogen therapy is introduced. So the assumption is that women who are younger than age 60 and less than 10 years from menopause will have no significant degree of atheroma. There will be some, obviously, with significant risk factors who might, and that would have to be taken into account if you are introducing estrogen-based therapy. The other thing which has been mentioned in the North American Menopause Society position statement in 2017 and is repeated in these guidelines is that no longer is there a specific time frame during which you should use hormone therapy and stop at the end of that time frame. It used to be 5 years based on the perception that risk of breast cancer increased significantly after 5 years, again, based on the reanalysis of data published in the Lancet in the 90s. The connection between hormone therapy and breast cancer, it has been recognized now, is much more complex and conflicting than was recognized then. And different progestins have different effects, different modes of administration of estrogen have different effects, and individual variation will make a difference. So the bottom line is that therapy must be individualized, and there is no specific time frame after which a woman must stop, or no specific age. With regard to mood, sleep, and cognition, the recommendation in management again is that there are standard options for management of depressive symptoms and major depressive disorders occurring during the menopausal transition and postmenopausal years. And these should primarily be antidepressant medications, cognitive behavior therapy, and behavior-based therapy. They do note that perimenopausal women may have a beneficial effect in terms of depressive symptoms with hormone therapy, specifically estrogen-based therapy, whether or not they do have vasomotor symptoms. And they recommend that the management of sleep disorders in the menopausal transition firstly should include education about sleep hygiene and ruling out sleep disorders, specifically sleep apnea and anxiety, and managing vasomotor symptoms. And they refer again to the importance of increasing aerobic exercise and including vegetables in the diet more often to slow age-related cognitive decline. For cardiovascular disease, this is not so much a change in practice, that short-term menopausal hormone therapy doesn't appear to increase cardiovascular risk, but the authors of this guideline do note that there is not yet high-quality data to say that one route of administration, specifically transdermal estradiol, is safer than another. But I'm thinking that that likely will come because the amount of observational data is overwhelming. And providing hormone therapy to women with premature, that is less than age 45, or early onset, less than 40 menopause, until the average age of menopause, appears to decrease the risk of adverse cardiovascular outcomes. And it does appear to reduce the risk of cognitive decline as well. In terms of genito-urinary health, they recommend that we simply keep asking about this and discuss with women who do have symptoms all of the therapeutic options in Canada, even those that are not yet marketed, that is ospemifene and vaginal DHEA. Vaginal DHEA will be available soon. And that low-dose vaginal estrogen represents a safe option and can be offered to women post-breast cancer, but the breast cancer guideline recommends that this occur after consultation with the cancer managers. For sexuality, the guideline notes that there are new agents for the management of low sexual desire and for genito-urinary symptoms, and that the possibility of using transdermal testosterone is there, but noting that it is off-label and that it has to be monitored carefully. And for osteoporosis, again, stating what has been stated in the guideline, that women who are at high risk of imminent fracture should be offered anabolic therapy. Anti-resorptive therapy should follow quickly. A drug holiday should be offered to women after 5 years of bisphosphonate therapy. And if there is the possibility particularly on bisphosphonate therapy of atypical femoral fracture, this should be followed up with bilateral full femur X-ray and bone scan. And in breast cancer, again, they stress that newer agents such as the TSEC, the combination of conjugated estrogen and azadoxifene, and steroid precursor molecules, vaginal DHEA, do appear to carry less risk overall of breast cancer than other agents. And women who have had a hysterectomy will have less risk with estrogen-only therapy than women who are forced to use estrogen plus progestogen. And vaginal estrogen can be offered, again, in women with a history of breast cancer. And the newer therapeutic options, DHEA, vaginal DHEA, and ospemifene, have been approved for use in women with a history of breast cancer. Now, this has an asterisk by it because the ospemifene drug monograph does say don't use it in women who have a history of breast cancer. So there are trials continuing to see if this is an option, but vaginal DHEA does not appear to be a risk in women post-breast cancer. And women who have undergone risk-reducing salpingo oophorectomy should be offered estrogen-based therapy because of concerns about other health risks, specifically bone health and heart health. So I think these are the recommendations and the suggested changes in management, but I sympathize with those of you who are sitting through this and thinking that's a lot of words. And actually the guideline fatigue syndrome is a term that was coined by a rheumatologist. So OB-GYNs are not the only people who are battered by the number of guidelines available. And I think I have some sympathy with this presumed trainee who's had enough with the guidelines. So again, Friday morning is where there is a half-day symposium with the authors of each of the guideline chapters, giving more flesh to the guidelines that they have prepared. And I urge you, if you can afford the registration fee, to attend it. So thank you, everyone, for your attention. And I think we have time for a couple of questions.
Thank you, Dr. Rowe. That was a very informative summary for all of us on a long guideline. So I think you saved us many hours of reading. Thank you. Okay. There are a couple of people here who are really interested in this Friday morning, and perhaps in the chat box, you could put the